15,000 new staff, neighbourhood teams, digital-first infrastructure. The NHS Ten-Year Plan promises transformation and reform, but at what cost? Will it result in new funding coming down to primary care or just GPs having their hands tied? Welcome to Katie Collin, Beyond the Balance Sheet. I'm delighted to be joined in this episode by my business partner, Laurence Slavin, who's another partner at Ramsay Brown, and he's going to be talking to us today about his views on the 10-year plan. Welcome, Laurie.
Thank you very much, Katie. Great to be here.
Yes. So I know lots about you, obviously, as my business partner. But just for our audience, can you tell us a little bit about yourself first before we launch in?
Sure. So I'm Laurie, or Laurence Slavin. I've been a partner looking after GPs and GP practices since the late 1980s. So I've experienced a number of major reforms in the NHS. I've seen the good, I've seen the bad. So what's interesting is going to be to discuss this with you today, Katie.
Absolutely. I noticed you didn't mention the ugly, so maybe we'll get onto that later. But obviously the 10-year plan's been announced. Lots of information going around, lots of opinions, comments. What's your take on it so far?
So I wanted just to read something very briefly.
Sure.
The 10-year plan. The NHS plan outlines a strategy for more doctors, more nurses, more beds, 100 hospital buildings, improved access to hospitals, primary care, renewed focus through performance targets, decreasing waiting times, a new model of financing. Instead of public money, the private finance initiative takes loans at high interest rates to design, build and operate hospitals. The plan also sets out revised targets for issues such as waiting times. All sounds great. And you could think that I was referring to the plan that came out under Wes Streeting. In fact, I'm not.
Okay.
I'm talking about what came out in the NHS plan, a 10-year modernisation programme in July 2000 from Alan Milburn. So, as Hegel said, what we learn from history is that history teaches us nothing.
That's so interesting. And so why did you choose to read that of that particular quote? What is really the crux of why that jumped out at you?
Because since my time working with GPs, there have been 18 major initiatives, and that's ignoring all the minor initiatives. 18 major initiatives, and the smallest gap between any of those initiatives is 4 years. So when I hear politicians talk about 10-year plans, even 5-year plans, what I'm thinking is, here we go again. It's top-down bureaucracy, and quite a difference to what's intended in this document, which talks about moving into the locality. But it's a top-down suggestion, and I think being an advocate for primary care, being passionate about general practice, what I think is that this plan, laudable though it may be, is deficient in detail, and my worry is it will just be another plan that ends up in the dustbin of NHS plans.
And it's interesting you used the word plan, because that's what everyone's sort of saying, the 10-year plan. Is it a plan or is it just a vision?
That's a very good question. I had a conversation with a client of mine last week. I see GPs probably every day of my working life, and I talk to them about what's going on in their practice, their PCN, their area. And this is somebody whose views I respect. And he said, this isn't a plan. It's just a statement of ideas, of aspirations. It's very hard to look at this plan and understand what it's going to mean for general practice. So general practice, most GPs work under a GMS contract. Some have a legacy PMS contracts, if you have APMS contracts. But these are lifetime contracts. Maybe not the APMS, but they're lifetime contracts. And there's funding that goes through these contracts from enhanced services and various other different sources. And what we don't know is what's going to happen now with these new neighbourhoods. Is the funding going to be diverted into those neighbourhoods? What does that mean for the financial security of those practices?
What have you seen so far from your clients or our clients in terms of this announcement of the 10-year plan and that lack of visibility over what that's going to look like?
I think I'd say there's a general lack of excitement because, as I say, we've been here before. And I think what was more telling was the comments that Wes Streeting made after this was issued, when he talked about that the really effective practices would be continuing. Well, what's a really effective practice?
Yeah.
And actually, I made a post on the weekend because what I thought was, I don't know any GPs who set out to go to work to be ineffective.
Mm.
They set out to be effective. And if they're not effective, it may not be because they're not wishing to be effective. It may be that their funding isn't straight, it isn't correct, isn't suitable.
Mm.
And the Carr-Hill Formula, which is mentioned briefly in the 10-year plan, it's talked about being updated. There was a positive response to that, and I think it's outrageous that the Carr-Hill Formula that was issued in 2004 was found to be defective about an hour after it was issued. We're now in 2025 and nothing has happened.
No. Well, they are saying that apparently there is going to be a review. I thought it was very interesting that I noticed in the review and the models that they're looking at, they haven't actually asked for any expert advice from any accountancy body or any group of specialist medical accountants who might have visibility over that. I don't think anyone's really been welcome to participate in providing comments as to why it's deficient, which I think was interesting as well to spot. But I suppose what's your experience of why it doesn't work, and maybe how would you look to change it?
So the really critical thing here is to understand how we got here. And as actually Nigel Edwards from the Nuffield Trust said in his comment on the 10-year plan, he said it's curious that the Health Secretary hasn't looked to see why haven't things worked in the past. Now, if you go back in time, and I think it is really important to understand how we got here, that before the 2004 contract, general practice was widely praised, widely thought of, more than I think it is today. But with that contract came the Carr-Hill Formula, which didn't work. Now, prior to that, we had something called the Jarman Index. So practices in deprived areas, they were given additional funding based on the Jarman Index, and it worked. Now, the Carr-Hill Formula, which was supposed to replace this, doesn't work.
And why is that, Larry?
Well, poor Professor Roy Carr-Hill got a lot of stick from his formula. What I heard, which I probably would believe, is that his formula was interfered with by the government departments. There's no secret that the Treasury don't like general practice, and we have a formula that doesn't work. But the solution to this, when this became evident, was to issue something called the minimum practice income guarantee or correction factor. And what that did, it retained GP funding at the pre-new contract level. So it actually made the Carr-Hill Formula obsolete. And that at least gave the practices the continued income that they were getting before. And the solution to dealing with the correction factor, or the MPIG, was to phase it out over a 5-year period and not replace it. So you had this, if I can put it as a festering wound of a Carr-Hill Formula that had a Band-Aid put over it for the correction factor, or MPIG, and then slowly removed over 5 years, but no improvement made to that wound. Now, in my take on this, as an advocate for general practice, as an advocate for the partnership model, is partnerships are adaptable, they're versatile, they're flexible. And what GPs have done is they've managed to adapt to their new world of having inadequate funding. So what you now have, rather than having a partner-led model that we used to have before the new contract, we went to partners who had salaried GPs, they had locums, bigger list sizes, which is the way that they were able to adapt to retain that funding. But then they're criticised for that. So the issue is the government needs to get it straight with their funding and not try and hoodwink people by saying, well, we're going to change the Carr-Hill Formula, everything will be fine again. It hasn't been fine for 25 years.
So it's interesting. So you said looking back at where we are. So I suppose, where did it go wrong? You talked a bit about hoodwinking. Where did that lack of trust build up?
Well, that's a very interesting question. And I'm not sure I know the answer to that. But I do know, because I was privileged to work with the review body for a period of 10 years, that the review body's recommendations were always accepted. Not only were they accepted, but they had their own means of measuring whether or not they had delivered the correct funding in a previous year. And if they hadn't, they made it up in the next year. And you contrast that now with a statement from the Health Secretary last week saying that they're not going to fund the review body awards because they haven't got the money.
No.
Well, the last people whose fault that is are the GPs on the ground doing the work.
No. And after we've seen this situation of the DDRB making recommendations, confusion over backdated funding, not knowing when it's coming into practices. We've now had months, haven't we, of GPs waiting to find out what's going to be funded for this DDRB recommendation, to now find in July, when the staff are all expecting pay rises, that actually there's nothing there for that. And that's changing plans mid-year. So it's really, really affecting people on the ground and how they make decisions and how they plan.
Correct. That's exactly right.
So I suppose what was missing from the 10-year plan that you would have wanted to see, or what do you think needs to be in there that isn't in there at the moment?
Well, detail.
Yeah.
I think the issue, I think the fundamental problems with it are it's too ambitious. As I say, none of the plans that I've ever seen have been wholly successful. Those that were successful, or those that were becoming successful, were then repealed by a different administration because they didn't like that particular plan. So what I would have liked to have seen in it was detail. The new neighbourhood contracts that they're talking about, what does that mean? Are practices going to have to merge to actually achieve the minimum 50,000 patient list size to do that? We don't know. What happens to the terms and conditions of their existing contract? Are they carried over into the new contracts? My worry is that the lifetime contract that GPs have with their GMS and PMS will be taken away. It'll be replaced by a shorter term contract. And the problem with that is you don't get people investing in their practices for the long term.
Yeah.
So I was privileged to give a talk to some registrars last year, something I do every year, part of their development into going into the big world of general practice and finance. And I asked them how many of them intended to be partners at some point in their career. No one put their hand up.
Really?
But this year, same talk, different GP registrars asked the same question. Around half the people put their hand up.
That's reassuring. That's good to see. And why do you think that change has happened then?
I think that change has happened in spite of government, in spite of health secretaries. It's market driven. Locums, a career as being a locum used to be something that was, you locum to fill in between jobs. You locumed while you were looking for your next long-term placement. But working as a locum has become a career choice. But the market has shifted. There isn't the same demand for locums for all kinds of reasons. And actually, those people are finding life being insecure. We've all read about locums working as Uber drivers, for instance. So there's been a shift. And the great thing about partnerships, I'm a real advocate for partnerships.
I can tell.
their flexibility, their adaptability, but they're also supportive. So if you're in a partnership and you have difficulties, you work together to resolve them. If one person is sick, one person wants to do something else, the partners work together.
Yeah.
And that's the great thing about partnerships. And my worry is that while things are looking more positive, is that this plan is just going to derail it and run us into another set of reforms from which general practice potentially may not recover.
Yeah. Interesting you talk about the partnership model. So one of the things that was mentioned in the 10-year plan was alternative models. And they didn't really give any detail around that. You and I know there's a lot of interest in terms of looking at different vehicles. So I would say sort of incorporated vehicles or limited liability vehicles for a partnership. Do you think that that's something that might happen? What would be your view on what these alternative models might look like?
So I'm really clear in my mind that whatever developments happen, whatever changes they make, they have to be built on really solid foundations. Now, if the foundations are right, I don't think it matters whether the GPs choose to work as a general partnership, a limited liability partnership, a limited company, a community interest company, a trust, whatever
Well, the list
you
is
like.
endless.
But I think the really important thing here, we must get those foundations right. And at the moment, there's just no detail. We
No.
don't know. And my concern is that the idea of general practice as it is, as small groups of people looking after their community, who understand their community, I worry that they're not being properly valued. And I come back to with Streeting's comments that the really effective partnerships will continue, and those that aren't, presumably, the alternative is that they don't.
And I suppose the danger is we don't know, what does effective mean? How's that being measured? What's that benchmark? What does that look like? So that's, I know, a concern for a lot of people. I wanted to touch on PCNs, primary care networks, because there's a lot in this plan that feels sort of confusingly overlapped with PCNs. We've got neighbourhoods, we've got PCNs, we've got practices, we've got trusts. What's your view on the neighbourhood model and how that's going in terms of what we've already got in place and how that might potentially work together?
Well, again, short on detail, but from what you can read from comments from people who know what they're talking about, apart from us, of course, Katie, PCNs who've got a population of more than 50,000 are ideally placed to move into a neighbourhood. You might ask yourself, why do they need to be a neighbourhood if they're already an effective primary care network?
Yeah.
But let's learn the lessons that we've learned from the primary care network model. Started in April 2019. We had a DES that spelled out what the PCNs, primary care networks, would look like, but nothing more. So we've still got some PCNs who are unincorporated, some PCNs who are incorporated. There was no thought given to pension access to people working in PCNs, no thought given to the tax and VAT consequences of PCNs. And I come back to the same point. What I worry about is the lack of detail, the lack of thought. Politicians are always big on ideas. The delivery is always left to the people on the ground.
Yeah.
And general practice is great at delivering. And these are ambitious targets.
Yeah. One of my clients called themselves the foot soldiers on the ground, who are the ones going to battle. And I think that's quite an interesting phrase to say, that they sort of feel disconnected with the, forgive my lack of military knowledge, but the commanders at the top, or the majors at the top, and they're the ones really doing battle on the grounds. And I think what we've seen with PCNs is there's so much administrative complexity in terms of how working at scale works when you're not one organisation, that we're now compounding that to another level where we've also got neighbourhoods. So we've got practices, primary care networks, and neighbourhoods. Are we not just layering, and having more and more and more? And interesting, you mentioned that the primary care networks that are 50,000 can stay as they are. We've got a lot of primary care networks who might be 30,000 and might be a practice and a network in itself. How's that going to change when they suddenly have to go into a neighbourhood of 50,000 and those dynamics? So, as you say, a lot of uncertainty. Interestingly, noticed it was announced that one of the ICBs in London has decided to make their neighbourhood integrators the trusts in that area. Not all of them, but the majority of them. Just interested to take your views on what you think that would mean for sort of the practices on a day-to-day basis, or what that might look like.
My concern is that there is a lack of control of what goes on in general practice. If the intention behind these reforms is to decentralize control, which I think is a great thing, it's something I've been talking about for a long time. If the idea is to decentralize, we have to have decision making and we have to have power in the appropriate place. And the more that goes into general practice, the better I am for it. It might work having the trusts, but my concern is that they'll have their own agenda, that they'll have their own self-interest or other interest at heart, but it could affect general practice. And I really think general practice needs to be protected and looked after.
In terms of putting power into general practice, is the difficulty not that you've got lots of different small entities that you're dealing with, and the idea then of a neighbourhood is that you give that power to the neighbourhood, and that then general practice makes up that part. Do you think that there maybe potentially the idea behind this is to reduce the administration of having to deal with lots of different individual GP practices?
Potentially. I think, Katie and I, we're partners together. We're a partner in a practice. We have chosen not to be merging with other individuals, other practices, because we have our own set of values, our own set of aspirations, our own set of social reasons for being in practice. And the same applies to general practice. I think I've dealt with more attempted mergers than successful mergers because, of course, it makes sense to have practices being larger entities than a series of individual entities, but that ignores the fact that the practices are run by people with their own motivation, their own set of values, their own set of desires. I mean, how many practices do we find that are separate practices within the same building, within the same health centre?
Yeah.
And they're never going to work together.
No.
Because they have different sets of priorities, different sets of values, and there's nothing wrong with that. But forcing people to work together, it never works. And because general practice is ultimately, they're self-employed, it's a market-driven industry, if it was sensible that they work together and merge, they would. You don't need to be forced together. It won't work. And we come back to the same concerns I had earlier, right at the beginning of this. 10 years to make all these changes.
Yeah.
How long does it take for two practices to merge? That's not a short period of time. There's the legalities, the finances, the staffing issues that have to be considered. All these things take time.
And interesting you mentioned that about practices in the same health centre, because what has happened is they've been put into a network together. So they're in a PCN together, not in a practice together. And those people who've chosen not to be in partnership together are now forced to work together in this unofficial capacity of an organisation that doesn't legally exist as a PCN, and that creates a whole host of complications with it, and they're being forced to work together. And what's really interesting from my perspective is, having worked on PCNs now for nearly 6 years, the best model in terms of reducing all the issues, such as the VAT, the pensions application, all those sorts of things, the best model is to merge. That's the way you get rid of all the risks of the liability, all the pension issues, all the VAT issues. But of course, that's the one thing that the majority of PCNs have opted not to do. There must be a reason why they've chosen not to do that. So they would rather incorporate and create a separate company that they're all shareholders in, then merge their practices together, and that's to maintain their autonomy. So do you think there's a risk that we could see, I suppose, a lack of integration at neighbourhood level, or maybe even a lack of engagement potentially with neighbourhoods at a primary care level? Do you think that's something that might happen?
So I was reading a report from the Nuffield Trust about the 10-year plan. What it said is that there is this spectre of private healthcare that is circling around the NHS.
Like a vulture.
Well, yeah, like a vulture. And I think the risk is that and I'm pausing because the other thing we need to mention is that general practice runs on the goodwill of its partners. And the average age of partners in general practice is rising because people have been put off becoming partners in general practice. So that's why I was so excited when I saw this group of young, recently qualified registrars who were looking to be GPs. The risks going forward, a lack of engagement, is real. You can't tell a group of people that they are independent contractors and they're free to make their own decisions, and then tell them that they have to do things the way you tell them to. It doesn't work. And GPs, as you say, the foot soldiers on the front line, they will walk with their feet. And that's the real risk. You were talking about primary care networks. I wanted to give an example. I'm sure you've got plenty yourself, Katie. Katie is our PCN specialist, after all. But I've got a practice, a PCN, 4 practices, all in the same health centre. And 4 separate practices. They've not merged because they have different values. And the clinical director was appointed from one of the practices. And it was an extremely unhappy time. And in the end, they've had to get rid of the clinical director and bring in somebody outside to act as the clinical director.
Wow.
Now, the idea, if I said to these 4 practices, I think it's a really good idea if you merge and you become one entity, I would be looking for more clients. They would have a new accountant, and it wouldn't happen.
No.
So that's where we are.
Yeah.
So there is a real risk. There is a real risk that this sort of top-down, we know best idea, it comes with risks. It comes with real risks.
So it's interesting you talking about the independent contractor status, because that's the thing that's really interesting about GP partners is they're independent contractors, but they're treated as employed for pension purposes. So it's there's been a lot of talk in the press about how it's made GPs feel being branded as not part of the NHS family for the national insurance increases. Do you think with this plan there's a potential risk to that independent contractor status?
Well, I've been doing this job for a long time, as you would have heard from earlier. And every so often, someone will come up and say, the independent contractor model is fragile, it's vulnerable. HMRC might take a look and say, well, we don't think these people are self-employed. As you say, they're members of an occupational pension scheme. Who else has that? There are risks. I think it has built-in efficiency. That's the thing that I think is so undervalued. It has built-in efficiency because the people who are running it, it's in their interest to make it financially profitable. And when I say profitable, I can imagine some people saying they're making profits out of their in general practice. But they do have to comply with their terms and conditions. They have to meet their obligations. They have CQC who inspect them. There are plenty of levels of regulation that general practice has to go through to maintain its integrity, to maintain its validity.
Yeah.
If they make profits and they're successful, it'll be because they are efficient.
And I think a really important point here is we talk about the word profit as if it's a dirty word, in the world of the NHS. But actually, this is essentially people's livelihoods. They're putting their personal liability on the line. And what you get is, from my experience, investment of someone who wholeheartedly is putting their whole life into their GP practice. I mean, we don't see people coming in and sort of doing a 9 to 5 and not really caring. They fundamentally absolutely care about their patients. And a lot of the meetings that I join, the conversation comes back to patients, patient care. How are we going to deliver patient care? If we're having our funding cut or this isn't being covered, how are we going to deliver to our patients? And interesting, you talked about, it being a good, profitable model. What we've seen is when those private providers come in, they can't make a profit from it unless they cut down the level of care so much that it then becomes non-compliant and they have their contracts taken away. So what you get is the intangible benefit of a partner who, as you know, from being a partner yourself, and I do too, the effort and time you put into something that you've grown yourself that we just don't see kind of in a corporate model at all. Just from personal experience, I think. So one thing we haven't touched on is there's a lot of talk in the 10-year plan about digital investment, digital infrastructure, AI, all those sorts of things. Again, sounds great. We're going to be really innovative. We're going to have loads of digital investment. Everything's going to be automated, single patient record. Thoughts, is that possible? Is that realistic?
Currently, 6% of patients use the NHS app. And this 10-year plan is predicated on saving money by using technology, by using AI, by having robots do operations. These are all fantastical ideas. And will they be successful? Will they get there? I would be skeptical if I say that. AI is in its infancy.
Mm.
So I can tell you a story that I'm at a
I'd
meeting.
love to hear it.
A meeting with a client last week. There's a series of meetings I've been having with him about what he should be doing with his practice and his private practice. And he came up with a plan which was different from my plan that he had created for him using AI. And he said, I want to discuss why this plan isn't as good as your plan. Why is your plan better than this AI delivered plan? So I pointed out that his AI delivered plan was potentially illegal, certainly would not be accepted by HR.
It's not a good starting point.
No, he was paying money to people for services who were not providing a service, were not employees. And I said, well, you just can't do this. You can't do this. And he was happy with my revision to his plan. But AI has its place. But it's very ambitious.
Yeah.
It's very ambitious in this plan.
I think what's really interesting as we talk about all the digital infrastructure and AI and how it's going to revolutionize everything, we can't really even get back to the basics of, I mean, how many practices do we see where they get money in and we don't know what it's for? That they can't track the income coming in. We don't know if it's PCN related. We don't know if it's practice related. We don't know what year it relates to. We don't know what service it relates to. Sometimes it doesn't even relate to their practice. It was just an honest mistake made by PCSE when they were paying the practice. I think if you can't get those basics right, it's all very well talking about AI, but on a day-to-day basis, we don't have any infrastructure. And I didn't see really a lot of acknowledgement in the 10-year plan about building that kind of infrastructure in. I mean, to me, I suppose there's a question of, would the trusts be the logical place to be the integrator because they've got that infrastructure? But you and I both know that we see on a day-to-day basis, the payments come through from trusts. They're not able to tell what the payment's for. They can't trace things back. You know, it's the getting the basics right before moving on to that further point.
Exactly. It's foundations, like I talked about before. You can build something. You can build something that's wonderful and fantastic. You've got to get the basics right. You've got to get GP funding right. That's the first thing you've got to do. Are we really going to have to wait for 2028 for a revision to the Carr-Hill Formula? Is that 24 years after it was proven to be ineffective? We've got PCSE who can't deal properly with GPs' pensions. We've got GPs retiring and not getting their pension because PCSE haven't got their record straight. We've got so many things wrong at a fundamental basic level. So one of the things, Katie, you will sometimes say to me is you'll say, Laurie, you have great ideas, but pretty poor on detail and delivery, and you're great at filling in the gaps. And between us, we can do all this. But I'm not sure who's going to be filling in all the gaps here. We've got the great ideas. There's nothing in there you can say is a bad idea. But I think most commentators I've seen, most comments you see, it's about the lack of detail, the lack of understanding, really, of how people on the ground are going to be able to deliver this.
Yeah. And interesting, you're talking about lack of implementation. I mean, now NHS England's been abolished, so that's going to go as well. And I suppose the theory behind that was to avoid duplication and to get kind of more funding open up. Do you think there's a risk that it feels like we're being told on the one hand, there's not enough funding, the NHS is really struggling, we have to make cuts, we have to be really careful. And on the other hand, then you get this 10-year plan, which is this amazing, we're going to be the best employer in the UK, we're going to be completely digital, we're going to have less waiting time. Those two ideas seem quite contrasting in terms of, well, we need to cut lots of spending, but also we're going to be amazing and brilliant. And do you think maybe, where's that gap? How do those two ideas meet?
So back in 1990, 4% of GDP got spent on health and 4% of GDP got spent on defence, for example. Currently, we're up to 9% of GDP being spent on health, and the government are aspiring to pay 2.5% of our GDP on defence. So that gives you an idea. We've got this massive increase in spending on health. And I think before we launch into a new plan with inevitable cost implications, There was a study recently that someone referred to, I think it was an OBR study that pointed out that the cost of technological change is always greater than the change that is delivered.
Yeah.
So we're in this position now. I think we really have to understand why we have got into this place. Why have we got this situation? As you rightly said, the idea of the reforms is to save money, cut bureaucracy, but we've been there, we've done that. Every area used to have a local health authority, and I mean very local health authority. There was one in Barnet, there was one in Enfield, there was one in Haringey. People there, the advantage was, of course, that people in those authorities knew exactly what was going on the ground, who the good people were, who the not so good people were, where to place resources.
And the practices knew who to talk to.
The practice had someone to talk to. And when there was a new initiative, so I remember fund holding coming in, that it was able to be directed to those practices who would best be able to manage it and benefit from it. That's gone now to this centralised system, which does not deliver. And now there's talk about decentralising this. But you can't do that cheaply. You can't do that cheaply. And we're going to end up losing people, good people, with these reforms, of that I'm sure. And you have to ask yourself, what kind of people are going to want to build a career in if I call it an industry, in a sector that is so changeable? Would you be a partner in a GP practice unless you knew you were going to be there for the long term? Would you borrow money to buy into a premises if you knew that you might not have a contract in 5 years' time? Would you be applying for a senior position in a neighbourhood board or a trust if you knew that, well, perhaps in 5 years' time there'll be another review and you may not have a job?
Yeah, it's really interesting. We've got this culture of everything being last minute and urgent. And I remember when the PCN contract was due to expire, and I think it was something like the 28th of March at 4:30 that they announced, over Easter weekend, they announced that the contract would be rolling forward. You just can't make financial decisions like that. And as you say, raising money to buy into a property, it's your whole livelihood, it's your whole career. I wonder how we've got into that cycle. I mean, was it always like that? That's certainly what I've experienced in the last 5 or 6 years, and I think it's got worse. But did we used to see that sort of 20 years ago, 30 years ago?
No. 20 years ago, we had something called the Red Book. If anyone's listening to this and remembers the Red Book, they'll have a tear in their eye with nostalgia when they think about the Red Book that governed their life. I still have a copy of the Red Book in my bookcase, and it was a Red Book, and it told you how everything worked. Everything you needed to know was in that. It was in that Red Book, and if you needed it, if you wanted it, the money would be there, the resources would be there. When we had a period of high inflation, for instance, and interest rates were high, the Department of Health, the government, created something called the General Practice Finance Corporation, a body that would be able to lend money cost effectively to GPs to buy into their premises. We're in that time again now. Is there any encouragement? Is there any help? None. You asked an important question, I think, probably much earlier in this interview, about what changed. Why is there this difference in approach from the Treasury, from the government? My view is that when the 2004 contract was being negotiated, it was negotiated between the BMA and the Department of Health, and the BMA negotiated a better contract than the Department of Health thought they would. It was never envisaged, because there were 1,000 QOF points originally. It was never envisaged that GPs would be getting 900, 950, 1,000 points. It was envisaged they'd be getting about 2/3 or 3/4 of those points. So the government, the Department of Health, the Treasury, were upset at how well GPs did. And we should learn from that. What we should learn is that if you give GPs a target, if you give them something to do, they will achieve it. Well, let's use that. Let's use that to create a positive outcome for patients, for the government, for the Treasury. Let's not try and recreate the whole world. We don't need to do it.
No. One final question I want to ask you, which is about continuity of care, because we hear this expression a lot. I know it's something you're passionate about. And certainly from my experience, having had my kids, we don't have a family doctor who is our person that we go to, our GP that we can call up who knows my kids. I know that's how I grew up. I was also lucky that my mum was a GP, so that was quite handy. But we're seeing a lot of talk now about this idea of continuity of care. How does that fit, do you think, with this 10-year plan?
Again, I think continuity of care it's desirable in most industries. I think it's essential in health. Our clients like dealing with us. They wouldn't want to be swapped around and have different people dealing with them. They like the fact that we know them, they know us, we know their history, we know what upsets them, we know what worries them. That's critically important, and you can't AI that.
No.
That exists from a personal relationship.
I would add as well that actually that makes us better at what we do, because the more we know about our clients, the better we can actually get to what the root of the problem is. And I'm sure most GPs would say sometimes a patient comes in, what they come in for is not always what they necessarily think it's what they're coming in for. And I think with our clients, the better we know them of what's going on in their lives, how they're working, the more we can structure the advice around them personally, which creates better outcomes. Granted, we're talking about finance, not health, but surely it must be the same thing for our clients with their patients.
Yes, absolutely. And again, if we want to learn from history, prior to 2004, when we had our Red Book, I'll wipe the tear from my eye later, but in the Red Book, it specified the maximum list size you could have as a partner. So you couldn't have a huge list. Now, I don't think it's necessary to have that kind of restriction, but if you don't fund general practice properly, if you have a defective formula and the practice has to have more patients to survive, which is what's happened, we come back to the same story. We haven't got the right foundation blocks in place. We haven't got a replacement for the Carr-Hill Formula. We haven't got deprivation being paid properly. Then perhaps the only way for practices to stay solvent, practices to become, to exist, is that they have to have a model of care which doesn't support continuity of care. And who loses from that? Well, we all lose from that.
And I think the idea of the neighbourhood model is to try and bring in this team around patients so that they've got this joined up care. And I mean, that can't be a bad thing. I've seen it when it works effectively and it's brilliant. But my concern, like yours, is that where does the continuity, who leads that? And the natural thing we always see in the past is the GP leads that, because the GP knows their patient. That's the point of primary care, their first point of contact. And what I see in the 10-year plan is there isn't the infrastructure or you say the foundation blocks to support that continuity of care. It looks like a good headline because we know that's what practitioners want, because it allows them to do their job better. So it sounds good, but I just can't see how in the model that they're proposing, we've got that ability for that. And I think that's a really sad point in time. We've got this conflict between what we think is actually for the best of patient outcomes, but actually we're not really able to deliver it.
I don't think anyone would argue that continuity of care is a bad idea. I think it's accepted that it's the best way to look after someone. So you could ask, why are we having this conversation? Because if that's been an aspiration for healthcare workers to look after their patients, why are we having this conversation that it doesn't exist? And we're going to come back to the same answer, Katie.
Let's
we're
take a theme.
The same answer.
Yeah, no, it is really interesting to see how things are going to evolve. So I suppose just to close, your final thoughts on maybe what would be your kind of one piece of advice to the health professionals out there of what you can see the 10-year plan, and what would you be advising your clients to think about?
So we could say I might give different advice to my clients, to anyone who's any decision makers. The advice to my clients is we've got to be really careful. We've got to study the detail and we've got to plan. a proper plan. We've got a plan for what is in, or what comes out of this, plan for survival, plan to change, whatever else we might need to do. If I'm giving advice to the people who are making the decisions, I would beg them to fix the problems that have existed for the last 20 years. I'd beg them to get that right before they start any major reforms, because it's just not going to work, and I'll be here in 10 years' time talking about the 19 major reforms that I've seen rather than the 80 major reforms that I've seen that have been cast into the dustbin of NHS reforms.
Absolutely. Is there anything GP practices can be doing right now on a day-to-day basis to make this easier? I know we've talked a lot about just even being financially aware of what's going on in the practice, and maybe it sounds really basic, but just being more clear and keeping books and records up to date, knowing your business, knowing where the income comes in, knowing what your costs are. We do a lot of benchmarking, as you know. Is there anything that you would really be recommending GP practices can do right now before that detail comes out?
I think what they should be doing right now, as you say, making sure their finances are straight, up to date, where they know where they are. I guess what I also might say is to review their plans that they have going forward. They may not want to make commitments, whether it be premises, whether it be new partners, until we have more detail about what this plan involves. We don't want anyone to walk into trouble.
No, and we've seen this as well with things like the DDRB recommendation, people who are paying pay rises without knowing what income's coming in. We've seen people stepping into trouble, that people step in trouble with making plans. Then PCNs came along, giving, again, pay rises to our staff when then the cap wasn't, the total cap wasn't increased. So it's difficult because I think there's a big period of uncertainty. We saw after the last budget, a lot of people not taking on more staff because they know what's happening with the national insurance. And then subsequently, the global sum uplift was announced. But at that point, 6 months had already elapsed of people not taking on more staff because they were anxious. So I think knowing where you are with your finances is really, it sounds like a very basic point, but I think particularly for people in healthcare, that's got to be the foundation for where they need to start to be able to build in proper plans and be able to flex.
I agree.
Brilliant. Well, thank you, Laurie. Thank you for your insights. As I know we talk hourly, but it's really interesting for everyone else to be able to hear your thoughts and your experience. So thank you so much for your time. I know it's very valuable, and an absolute pleasure.
Thank you for the opportunity.
Well, thank you for listening to Beyond the Balance Sheet. Thank you for joining me today to listen to Laurie talking about the 10-year plan. Feel free to subscribe and follow us, and we'll catch you at the next episode.